Today I'm going to speak about minimally invasive surgery, so-called microscopic surgery. I'm just going to give a bird's eye view today and just highlight some of the common conditions and surgical diseases that we can treat here at Coosa Valley Medical Center. This is a bird's eye view of Rome. I realize Rome wasn't created overnight, but hopefully over time we can continue to grow together and provide these services here. First, I think a good thing to do is before you check out any type of surgical procedure, you should keep close mind as to who your surgeon is. I trained in New Jersey. I did my thoracic surgery residency at UAB. I was board certified in 2008 and got recertified in 2017. That's actually the maintenance of continuous certification. The wording has changed, and board certified in thoracic surgery, surgery of the chest, this year. And one motto that I like to practice by is the 3 A's, being available, affable, and able. I am here for you, as Vanessa had mentioned. I've been here for 12 years, and this is the only hospital that I work at. So why less invasive? Let's take a closer look. Why use less invasive techniques? Can less invasive techniques contribute to less pain? Possibly. Are there cosmetic reasons? Through smaller, tiny incisions that can be handled with just a bandage rather than a big open wound with larger dressings. Biomechanics, we preserve the muscles and the skeletal system to preserve our function, enable us to get out of the hospital quicker and return to our activities and hobbies and job-related activities. Cost, is minimally invasive surgery cheaper? Is it more expensive? Stay, typically, minimally invasive surgery can lead to short hospital stay. With our current time and healthcare, the way it has been evolving, there is a push to get patients out of the hospital quicker, and this is definitely a benefit. Activity, the end goal is to get you back to doing what you enjoy doing. Narcotics, there's definitely a big push to use minimally invasive techniques when indicated to allow us all to decrease our pain, medication usage, which can also lead to problems with addiction. And inflammation, lesser invasive techniques can lead to less inflammation in the body and quicker wound healing. A brief note about the history. The history of laparoscopy, which is the visualization of the abdominal cavity, the belly cavity, was first described by Hippocrates around 460 BC, before Christ. In 1900, that gentleman in the upper right-hand corner is George Kelling. He was credited, and also in the right lower slide, he's credited with first looking inside the abdomen, the belly of a dog with a cystoscope. Fast forward that a couple hundred years, now in 2018, we have a minimally invasive operating room on steroids. No pun intended. This is just to put things into perspective. We have the Da Vinci robot, although we don't have the Da Vinci robot here at Coosa Valley. I just want to enlighten you that there are many things, a multitude of things that couldn't be done 25 years ago, like Ms. Vanessa had said. As you can see, the upper slide there, the surgeon is at a remote location in the operating room, visualizing in a console and actually working these arms to perform major surgery. You see the team working there. And there are many things, and this is just one example down in the left lower slide of mitral valve repair, replacement. We can operate on the heart, the prostate, and other conditions. So what is laparoscopy? Laparoscopy is minimally invasive surgery that allows us to operate inside the abdomen through several small, tiny incisions under general anesthesia while the patient is asleep, utilizing long, thin instruments placed through small incisions in the body while viewing it on a monitor with our operating room team at hand. You'll have a surgeon, an assistant, and other assistant people in the operating room helping with the operation. So it's definitely a team approach, but proper patient selection is the key. Laparoscopic. You may ask yourself, how is this achieved? Well, this is just a side view of the abdomen, of the belly, where you have the intestine, the uterus, and other organs. And surgery is visualized on the monitor that I had just showed you through this laparoscope, which comes in a variety of sizes, 5 millimeters, 10 millimeters. We're talking millimeters, almost a centimeter. And we blow the belly up with gas, which is carbon dioxide. We place a small needle through the abdominal wall. We create a space for us to work in utilizing carbon dioxide, which actually acts as a retractor and a dissector to enable us to see what we're doing. So these incisions that we place, as you see, are millimeters, 10 millimeters, 5 millimeters, and we vary our incision placement based upon what procedure we're doing, whether it be gallbladder, whether it be hernia, an appendix, or if we're operating on the stomach. And as you can see in the left lower slide there, the slide here depicts incisions that would be used still for other procedures through an open approach. This slide here, number 1, this first incision represents the incision that we did many years ago, 20, 30 years ago, doing a gallbladder surgery. Today, it's the standard to do gallbladder surgery through 4 small, tiny incisions. That is the standard today in 2018. And as you can see, this slide represents the end result where the patient has less tissue injury, smaller incisions, very low maintenance. They can be accomplished and treated with just simple bandages. So now I just want to discuss a little bit about how we actually go about doing that. We place these trocars, which are plastic cylindrical instruments that go inside the abdominal cavity, so we don't puncture the bowel. It's actually the space around the bowel called the peritoneal cavity, and this is where the gas actually insufflates and it blows up the belly like a beach ball to spread everything else apart to enable us to work and see exactly what we need to see, whether the liver, the gallbladder, the uterus, the colon. And this is very safe. No procedure is bulletproof, but nonetheless, with proper technique and adequate visualization, it's a very, very safe procedure. General principles, as you see, this is a live patient under general anesthesia. The head is to the top, the feet are to the bottom, the trocars are placed, and this is a live representation. We have the tube that connects to a carbon dioxide insufflator where the belly is blown up like a beach ball, and we can get to any region of the abdomen and operate on any organ. These are just an example of the instruments that we use, and as you can see, they're very long and thin, and these are actually smaller than the incisions. So these instruments are maybe 2 or 3 millimeters in diameter, of which can cut, grab, cauterize, burn to control any issues that we may have during the procedure. A tap block is a transversus abdominis plain block. Instead of using an epidural before your surgery, in order to decrease the amount of pain that we all experience during surgery, the anesthesiologist, and we have a great team here, that will use an ultrasound probe, and under ultrasound guidance, you see the plane here like the layers of a sandwich, and we get the needle in the proper position, and we use this needle, which injects the solution, the anesthetic agent, to block all the nerves, and this lasts about 24 to 48 hours. Some anecdotal reports of longer than that, so it decreases the amount of pain medicine that we have. Patients get out of the hospital the same day, whereas before they would have to take 2 or 3, maybe 4 days in the hospital, and this would decrease the amount of other medicines that the patients would take. So, I don't know about y'all, but this makes me cringe a little bit, except in childbearing, where C-sections, it's still a necessity. We do not need any more epidurals, and epidurals have their own risks. You can get a spinal headache, bleeding, infection, and other associated issues. So now I would like to just discuss several common events that we can take care of here at Coosa Valley Medical Center, which is the gallbladder. You see that little organ there, the green guy living under the liver. It stores and concentrates our bile to help digest our fats, and we take it out laparoscopically. After you've had your studies by your family doctor, whether or not you got an ultrasound, where they rub the jelly on your belly and they detect the gallstone within the lumen of the gallbladder, or you may just not have a gallbladder that's functioning properly. We make our incisions accordingly, as you see, and using the monitor, we take out the gallbladder. This is the gallbladder here, and utilizing our long thin instruments, microscopically take out the specimen, and as you can see, the gallbladder is filled with gallstones, and you can get back to your normal daily activity within 24 hours. Patients go home the next day. Realistically, if it's a straightforward case, you can get back to work within 2 or 3 days, have a little bit of discomfort, but much less than you would have to do 20 or 30 years ago. Appendicitis, as you can see, this patient is experiencing abdominal pain, which may have led to a CAT scan. We have representative findings of pain, fever, rebound, and the diagnosis is that of appendicitis, which is a small organ that lives off of our colon. It gets so inflamed, one of the most common surgical emergencies that we treat here at Coosa Valley. Again, done under general anesthesia through 3 small tiny incisions. Depending upon the case, patients can even perhaps go home the same day. And this is just a live specimen showing us that the appendix is removed with our long instruments and the inflamed appendix is taken out. Another condition, patients that have had surgery, we're talking about surgery today, there are adhesions, which is scar tissue that forms inside the abdominal cavity, which can lead to a bowel obstruction. And with proper patient selection, if we can accomplish this and break these adhesions apart to allow the bowel to work properly, it can definitely contribute to decreased length of stay. And patients can get out of the hospital, if not the same day, perhaps in 2 or 3 days. Another classic story is we have a patient working at NEMAC or Honda or just working out in the yard. They feel a bulge in their groin and they develop a hernia, which is a weakness in their groin. We can actually do the classic repair where we would actually have to make an incision. We would actually repair the floor of the inguinal canal with the mesh, the so-called plug and patch repair, which is the time-honored approach, which is perfectly acceptable. However, laparoscopic surgery is definitely a good alternative where we can accomplish the same goal and fix the hernia through 3 small tiny incisions, and the end result being small incisions. The recovery time may be a couple of days quicker, and this is a perfectly acceptable alternative. Both approaches are perfectly safe and effective. Hernia surgery laparoscopically through a minimally invasive approach. Typically, if the patient has hernias on both sides, you can quite imagine that an incision may be more painful. So if we can go through the minimally invasive approach, that would be better. Or if the patient has had a recurrent hernia in the groin, sometimes the minimally invasive approach is much better. And it's just a different way of viewing the anatomy. This is just a depiction. It may not mean much to you, but we're visualizing the defect through the abdominal cavity, and this is where our mesh would be placed. Another hernia that we always treat is called an umbilical hernia, a hernia through the belly button. As you see, classic pictures here just to give you an idea. And every patient selection, every case is different, and we pick and choose which patients would benefit. If there's multiple hernias, perhaps a laparoscopic approach through 3 small tiny incisions would be good. As you can see, this is a very big defect. Not all hernias can be done laparoscopically. A ventral hernia is a hernia on the front of the abdomen, away from the belly button. As you can see, this hernia, very big, long-standing, probably not going to be done laparoscopically. Based upon your studies, if you get a CAT scan, we can see if there's any bowel involvement or any adhesions that I had just described. If the patient's an acceptable candidate and has good anatomy and other factors, if they have COPD or obstructive sleep apnea, and we want to avoid a big incision on their belly, a laparoscopic approach would be acceptable. However, just realize that, if we can't do it laparoscopically, we can always convert to the open approach. An incisional hernia, every time we go into the belly and make an incision and operate, for whatever reason, we develop scar tissue, and if we want to go in and fix the hernia, we could either do it the open approach, but laparoscopically through 3 small tiny incisions would be ideal. Again, if the patient has other comorbidities, emphysema, sleep apnea, if there's a risk of remaining on the ventilator. A lot of these hernias are a Swiss cheese deformity, meaning there's a lot of different defects. So if we can just make 3 small tiny incisions and place the patch underneath like we're repairing the ceiling. This is the concept where we're repairing the abdominal wall with the patch, and we just tack it up. No more sutures. It leads to less pain and less morbidity. Patients can leave the hospital the same day, whereas if you had to make an incision, the patient could remain in the ICU, remain in the hospital for several days. Another example of utilizing minimally invasive surgery through 3 small tiny incisions is if, for example, patients have diagnosis of cancer, a topic we don't like to discuss, but we want to make sure that we can help the patient. We don't want to hurt the patient, and we want to make sure that surgery is indicated. So if we put our camera in and we discover that there's metastasis, spread of tumor on the liver, or along the abdominal wall, they may not be a good candidate. They may need to see their other doctors and receive other appropriate treatment, whether that be chemotherapy or radiation, and we would not want to put the patient under any more pain or suffering. Realizing that any of these procedures, we have to realize, could result in a long incision in the abdomen, which could lead to a bigger procedure with more retraction on our abdominal wall, which can lead to an ileus, which is a lazy bowel, prolonged hospital stay in the ICU, and many days in the intensive care unit, possibly on the ventilator. Again, if we could do it laparoscopically through several small tiny incisions, that's a bonus. And the other risk is that sometimes with a big incision, I put this in here, I don't know how many people saw the wound back, but sometimes that leads to other complications and issues with wound healing and whatnot. Even though we do surgery through several small incisions, these little wounds are much easier to handle than a big wound, as you can quite imagine. Colon resection. Definitely, with the advent of colon cancer screening, you would come in for your colonoscopy. This is a picture of a normal colon. We treat conditions of colon cancer, diverticulosis, which are little outpouchings, little weaknesses, like the blisters or the weaknesses on the inner tube of a bicycle tire. Sometimes they can cause a bowel obstruction, and we can actually remove any portion of the colon. So if we can accomplish this laparoscopically, again, proper patient selection would be the key. If they've had no previous surgery, if they have favorable anatomy, these patients can typically be discharged from the hospital within a couple of days. We get all of their devices removed, get them up out of bed quicker. But again, proper patient selection is the key. We want good outcomes. This is just a cartoon showing that we can accomplish the same procedure as we do it open through long instruments that I had showed you. We can get good margins, remove the tumor, and do a good cancer operation. Doing surgery in the belly for colon resection, which has been around since the 1990s. And I should mention, even though it's been around since the 1990s, a majority of the colon resections for colon cancer are done open across the United States. However, a small percentage are done laparoscopically, and I think this is beneficial if you have the proper patient. We use these softer tissue retractors, not these big metal retractors called the Alexis retractors, which are these cylindrical plastic cylinders that can be folded and rolled down like you're pulling down your sock into the abdominal cavity, and they provide good retraction, which don't distort your abdominal wall and put a lot of pressure, and we can actually use them while we have the abdominal cavity insufflated with carbon dioxide, and we can actually put our instruments through this retractor and even put our hand in. So it's essentially a hand assist. It's a hybrid of the open procedure in order to remove the colon. Again, patients go home in 2 days, a lot less morbidity, less ICU stay, a lot less pain medication use. One thing that I should also mention, just for educational purposes, there is a condition, a procedure that we can do called TAMIS. I do not do it, transanal minimally invasive surgery, but just enlighten you to the fact that we can also remove very superficial early stage rectal cancer in the 70, 80, 90-year-old age group that may not be able to tolerate a very big operation. Another condition that we can treat is reflux, where you may have that heartburn, sour water brash feeling that comes into your throat at night just from the acid going up into the esophagus, into the swallowing tube from a defective sphincter. That LES, that lower esophageal sphincter, that is weakened. Once you've received your appropriate studies from your family doctor or other healthcare providers, we may need to get a barium swallow to check the anatomy, make sure that you're an acceptable patient. You may need to have an upper endoscopy or the scope that you're all familiar with. We may even need pressure and function of the swallowing tube to see if you're a proper candidate. And if we discover that your sphincter mechanism is loose, or if you have a hiatal hernia, and if you're an acceptable patient for a laparoscopic procedure, minimally invasive, we actually wrap the top of the stomach around the swallowing tube in the abdomen to create a new sphincter to prevent that acid that we just showed you going back up into the esophagus. Diagnostic laparoscopy, sometimes we don't have a diagnosis. Very common scenario, young female, 25 to 30 years old, having right lower quadrant pain. We don't know if it's her appendix. We get a CAT scan, very confusing. Very simply, we can just bring the patient to the operating room, pop our scope in, use these minimally invasive cameras and dissecting instruments that we have. Take a look inside. We don't know if it's her uterus, her ovaries, her fallopian tubes, is it her appendix? And we work together as a team. If we need other consultation in the operating room, they're just a stone's throw away, and we can always ask for other advice. Let's switch gears. Not only doing minimally invasive surgery in the belly, we can also do minimally invasive in the chest, which is called Thoracoscopy. This Hans Christian Jacobius was first credited with looking into the chest cavity, treating a patient with tuberculosis in 1900 with a cystoscope. As you can see, we've come a long way. And why thoracoscopy? Why do surgery through 3 or 4 small, tiny incisions in the chest cavity with a camera, with our dissecting instruments? Well, if you can quite imagine, if we had to make a big incision, which is sometimes possible, it spreads the muscles, it compresses the nerves, and can cause some pain on our ribs, which, as we had described, can lead to longer ICU stay, more medication use, perhaps a little bit more physical disability, and slower return to work. And we can achieve any type of procedure utilizing thoracoscopy, utilizing these 4 small, tiny incisions with our instruments. The incisions that we make, we plan them accordingly wherever we're deciding to work, whether in the upper portion of the chest, the middle portion of the chest, or the lower portion of the chest. This is just a variety, just like we do with our gallbladders and our hernias. This is done under general anesthesia, and you do have to go to sleep, and we do put a breathing tube in, but in order to keep the lung quiet so it's not inflated, we actually ventilate and breathe on the other lung for you, and we have an excellent team here that is capable of handling those issues and taking a look down in your airway and making sure that that happens appropriately. Just like the tap block, we don't have to use an epidural. We use a thoracic field block, which, under ultrasound guidance, we use small needles to inject and anesthetize the nerves as they come out of the spinal cord, and this provides long pain relief. Again, the whole key of getting off strong narcotics as quickly as possible. This is just a depiction of the operating room team performing video-assisted thoracoscopy, doing surgery in the chest through several small, tiny incisions with a video camera. As you see, we watch everything on the screen, just like when we operate in the belly, and we can do surgery on the lung and other areas. A couple of game changers that have really made a difference in the field of minimally invasive surgery, and I just want to bring them out to you. The stapler and the energy source. The stapler, which can cut the tissue, it can cut and seal the tissue, just like doing it manually back in the old days where we actually had to sew the tissue together. It's very safe, it's effective, very low complication rate. We can cut the gallbladder out, cut the appendix out, cut the colon out, cut portions of the lung out, very safe. And it can articulate, which can go in very many different directions to enable us to get to certain areas of the body. And this is a harmonic scalpel, not like the regular cautery that we use. It causes less tissue injury. It creates very good visualization for us in the operating room, and it comes in a smaller size. So not only operating in the belly or the chest, but this smaller device could be used for thyroid surgery, breast surgery, and hemorrhoids, which will really make a difference in your surgery. And the retractors that we had showed you, this is just a depiction of a patient's chest in the operating room, and these small, softer retractors are able to provide good exposure. They don't compress the nerves or the ribs, and they do just as good as a job as the larger retractors, and they cause less tissue injury, less inflammation, and contribute to quicker wound healing. Again, just being mindful of smaller retractors, not having bigger retractors, and this is the chest where the head is here and the feet are here. Again, the whole concept of less is more. And if we do operate in the chest, yes, you will have a chest tube. Just one quick note of that. Anytime we operate in the chest, we have to put a chest tube in. Some conditions that we can treat with breast cancer screening and breast nodules and colon cancer and prostate screening, we have the National Emphysema Trial out where we're actually trying to cut down on lung cancer, patients who smoke, certain age groups, 50 to 60, 70 years old. This is a CAT scan which has picked up a lung nodule, and these lung nodules could potentially be benign or malignant. I mean, they may not be cancer. They could be just a benign process from previous infection from living here in the South or other areas of the United States. We can work them up. We have certainly all of the services here at Coosa Valley. We can do a CT-guided needle biopsy, as you see, the radiologist trying to get tissue to determine what this nodule is, whether or not the patient needs surgery. This is just a cartoon representing that under ultrasound or CAT scan guidance, as an outpatient, we can get a tissue sample. You may need some other studies. And again, VATS lung resection, video-assisted thoracoscopic resection, through small incisions, smaller retractors. We can use our staplers and small instruments and operate in the chest to remove that lung nodule. This is just a depiction of the operating room team looking on the camera as they are working inside of the chest. This is the lung, and this is the stapler transecting that portion of the lung where the nodule is right here, and very safe for cancer operations. And patients typically are discharged from the hospital within 3 days. You will have that chest tube, and perfectly acceptable for patients that may have other conditions. COPD, obstructive sleep apnea, and if they're sick and have other related medical conditions, this minimally invasive approach may be to their benefit. Other conditions and linings of the chest wall, mesothelioma, you may have seen the commercial, which is due to asbestos-related conditions. At least we can make a biopsy here. Treatment for mesothelioma involves a very, very big procedure, but if we can at least make the biopsy here and get them to Birmingham or perhaps another larger institution where they can be treated, or perhaps to other oncology services here and get treatment, we can definitely play a role in that regard.